every year there's a new trial that gives us a new number on what our blood pressure should be. So let's hope that Dr. Mende can clarify it for us today.
Well, good morning, and Dr. Khan, thank you very much for inviting me. It's a great pleasure to participate, and these were already 3 terrific lectures. I actually made a lot of notes, and that just shows you how helpful this symposium is. So my duty is to keep you from, not only to keep you from lunch, but to give you a summary of what is new and how we treat hypertension in 2019. And actually, there are so many journals, about 5 of them just devoted to hypertension. And I submitted some slides, and I actually last week, after I submitted slides, I added 2 more slides because new data came out. So let's get started. So basically, these are my disclosures, and none of them will have any importance because essentially all the drugs for hypertension are now generic and therefore much more affordable. The prevalence of hypertension in the US has gone up, not because we have more people with obesity and bad diets, as we heard earlier today, but because we actually changed the guidelines. So if you lower the blood pressure goal by about 10 millimeters systolic, you will capture a lot more people. So as of now, we have about almost 50% prevalence of hypertension, and that's for adults, and that's over 100 million people. And how did we get there? Well, we still have the perfect blood pressure less than 120/80, which goes back to the Metropolitan Life Insurance in the 40s and their data. And we used to call pressures from 120 to 129 pre-hypertension, so we did away with this. We call it the elevated blood pressure. But now we have a very firm number after age 21, whether you are 80 or 75, or whether you have diabetes or no diabetes or CKD or what have you, you have hypertension if your pressure is above 130 over 80. And if it does reach 140/90, you now have stage 2 hypertension. And as you remember, the hypertension definition a year or 2 ago was 140/90, so we're down by 10 systolic points, and the stage 2 hypertension is down by 20/10. So it used to be stage 2, 160/100. Now it's 140/90, and we've completely done away with stage 3 and 4, which was 180 and 200, etc. So these numbers all have disappeared to make it very simple. So if you say, oh my God, now you're calling everybody hypertensive of 130, this is just an idea by the pharmaceutical industry to give write a lot more prescriptions. But actually it's not the case, because we now do something which we have not done until about a year and a half ago, that we actually look at the ACC, the American College of Cardiology calculator. So if your pressure is between 130 to 139 systolically, you look at your risk. If your cardiovascular risk from the ACC calculator is less than 10%, which is fortunately 2 out of 3 people, you do not treat them. So what you actually do is you do lifestyle things. I'll get into this in a moment again from a hypertensive standpoint, and you give them 3 to 6 months to shape up, quotes unquote. And if they have not done any, or their pressure is still elevated after 3 to 6 months, depending how urgently you need to lower the pressure, you will then start treatment. If, on the other hand, you are already have a risk above 10%, and that, again, is irrespective of your age, you start the patient immediately. So none of this delaying, which we used to do, which leads to sometimes patients not coming back for a year or longer. So basically, we become much more aggressive that if you have a 10% plus risk, you are started immediately if you're above 130, and that's a third of the patients. So why did we do that? So if you actually look at lifetime studies, and this is a cardiology study meeting, you can see that if your pressure from age 20 or 30 on or 40 for the rest of your next 30, 40, 50 years of life expectancy is between 130 to 139, you actually double your risk of a myocardial infarction. So these were the compelling numbers to make the 130 the new normal and the new definition of hypertension. So what to turn this around. So what would you then do with somebody who is above 130/80? And we'll get into this, how often you need to confirm this, so one reading doesn't mean too much. So what do you do with those individuals? So if you have already established coronary artery disease, you had a stent, you have angina, you're above 130, you treat immediately. And if your risk is 10% or greater, you treat immediately. But if your pressure is above 140, you don't care whether you had a risk factor or you had an event, you also immediately treat it. So this makes it actually very clear who gets lifetime, style changes only, or who is immediately treated. So this is extremely helpful and straightforward. So I just going to give you a couple backgrounds and say why did we move the pressure down to 130/80? So if you actually look at somebody who has a blood pressure above 140, let's just say you and I are 60, 70, or 50 years old, whatever we are, and you're walking around with a blood pressure of 145, which you think, it's not all that bad. But if you would take that individual and lower their pressure from 145 to 135, so you go down by 10 millimeter and you follow them for only 5 years plus, look at what you eventually can achieve. You have a reduction of CHF of 28%, 27% stroke, and you even look down at all-cause mortality. So basically, you have a tremendous long-term benefit in that individual with hypertension. And again, if you are on dialysis, you don't get the benefit. And I'll show you in a moment, if you have diabetes, whether it's type 1 or type 2, or you have CKD, which basically means your eGFR is below 60. That's the most commonly accepted definition. Or you have albuminuria. So by the way, if you have albuminuria, you have over 300 milligrams of albumin in the urine. Even if your eGFR is 80 or 90, you have CKD. So albuminuria by itself gives you the diagnosis of CKD, not just an eGFR of less than 60. So the benefits for CKD or diabetes are about half. So you still get benefits, but it is less than when you don't have CKD and you have diabetes. And if you actually look at eGFRs of 55 or so, there is already a slight increase in acceleration of arteriosclerosis. But if you go down to an eGFR of less than 45, it becomes as bad or worse than a very high LDL. So, and we don't know why. So CKD by itself is actually a very significant risk factor. It was added last year to the hypertension, hyperlipidemia risk factor in smoking, which the American College of Cardiology has. So CKD now is being recognized, particularly below 45 ml, as a major risk factor which for arteriosclerosis and cardiovascular events. So this is the story here. So here are the numbers for the diabetes. They're half. So you get about double the benefits, about 24% benefits if you have non-diabetes from 10 millimeter systolic reduction, but you still get 12% reduction of risk from 5 millimeters by a diabetic. And again, that compares with the A1C, which doesn't lower cardiovascular risk very much, but it reduces microvascular disease. And people always are sort of stunned and say, what is microvascular disease in a diabetic? It's the pathies. It's retinopathy, neuropathy, and nephropathy. So eye, nerve, and kidney disease. That's why you and I chase A1C. So you lower the A1C by 1%, and these three pathies reduce your risk by 37%. So of course you treat both. So you treat the A1C in the diabetic, and you treat the blood pressure. So here came the study which changed our attitude and actually was responsible for you and me to call hypertension now at 130/80. This was the SPRINT study. So it took people who had blood pressures in their mid-30s to early 140s and lowered one group down to 121 and the other one 136. So there was a difference of 15 millimeters systolic. So why I'm not talking about diastolic anymore, the diastolic blood pressure is very rarely elevated after age 50. So from age 50 on, we live in a systolic blood pressure world as far as side effects are concerned. Now, of course, if you're 180, you may have a 100, but still the systolic leads. But there are individuals in their 30s, particularly African-American males and females, who have a blood pressure of 135 and 100. So you see more diastolic hypertension in the very, very young. But by the age 50, it turns around, becomes a systolic world. But look at these reductions. This study had to be stopped after 4 years, although it was planned to go on for a whole 5 years because of these tremendous reductions of 42% of cardiovascular events. But again, they didn't show that much benefit if you lost 50% of kidney function, so you're down to your 30s or 40s millimeters, and you showed less benefits if you had on dialysis or you had a significant established cardiovascular disease. The trouble with that study is you cannot take that number and correlate what you and I do in the office, because this was done in an artificial research world. The patients were in a dark room. Nobody talked to them. They were not allowed to talk to the individual. The technician left the room while the physician wasn't there, and we use automatic Amaran. And I can tell you that what is happening in the hypertensive world, that within hopefully 3-4 years, all of us will stop using any gadget which is not oscillometric. So it has to be the automatic blood pressure measurements, which you do at home with the Amarans and the Sunbeams of this world, and they're down to less than $30 at Costco or Save-On, wherever you want to buy them. They're much more reliable than the old sphygmomanometric methods. So this is where we go. So basically, what's the bottom line? If you see the number from Sprint, you mentally should add about 10 millimeters. So Sprint said the perfect blood pressure for them was below 121. It is below 30 or so for you. So this is why we got to the 130. And so I went in the literature and I could have found more studies. And so the automatic blood pressure with the oscillometric measurement, like an Amaran or what the hospitals use, is very similar to the ambulatory blood pressure, which is the gold standard, or a home blood pressure if it's done correctly. And so what is the correct blood pressure? I think the most important is that you empty your bladder. If you go to see a doctor and your bladder is full, male or female, your systolic will be up 5 to 8 millimeters more. So first, empty your bladder. Second, they take you down the hallway and you barely set down the Tokyo pressure. Wrong. So you got to sit a couple of minutes so your pulse rate goes down. The third large mistake is to put you on that examining table. I want you tomorrow to take your blood pressure on Monday in your office. You take it sitting down, back supported, both feet on the floor, not crossing your legs. Then you sit on top of an examining table. The legs are swinging, the back is not supported. You will not be surprised the systolic will be 8 to 10 millimeters higher. I go and see my physicians and the nurse or whoever takes my pressure, and the first thing they do is sit me on an examining table. Oh, I'm saying nothing because they think, the first thing guy says as a physician is he complains. So I usually shut up, But basically, so at the end, sometimes depending how I feel, I'll say, by the way, from now on, please do me a favor. So basically, these are the rules of engagement, and they're very strictly written in the guidelines. But who looks at the guidelines? I mean, I don't, if I get a new gadget at home and I always try it out. My wife says, why don't you just read the instructions? But I never do. So when you do this, you'll see that it compares very nicely. So basically, there was this diabetic study. So it said that if you took the diabetics down to less than 120, they actually didn't do very well. So what they forgot to tell us, and this is analysis from a couple of months ago, that they also took them down to less than 6.5 with an A1C, so they had a lot of hypoglycemia and more mortality. So basically, if you take a diabetic below 130, we'll get to the number in a moment, and maybe down to 125, if they can tolerate it, they will benefit if you don't also get the A1C down to low. So basically, lowering of blood pressure in a diabetic below 130 is very beneficial, and only do you lose the benefit if you also make them all the time hypoglycemic by lowering their blood sugar excessively. So there was another trial which just got published a couple days ago. I just put this slide in 2 days ago. And this is a huge diabetic study over almost 11,000 patients. And they had pressures in the mid-30s, like 135, 140. And they just give them perindopril in dapamide, but you could use any other drug. And they lowered the blood pressure by 5.6 millimeters systolically. Look at those numbers. And they had 9% lower events in 4 years and 18% reduced mortality. So basically, even if you're at 142, 143, 138, even if you're in this rather benign group, but you still significantly above 130, you see these kind of benefits in some 4 years. So I'm just trying to show you that 4 or 5 millimeters in the long term, particularly if you have type 2 diabetes, do make a big difference. And there's one thing I need to be, you already know this, I'm a nephrologist, so basically it's the issue. If you lower blood pressure, particularly in a diabetic aggressively, let's say they're 145, and you get them down to 125 in a week or 10 days, you will have about 10% of them who their eGFR significantly drops. So they have a eGFR of 65, 70, and they may go down below 60. So you have new onset of CKD. So basically, many of them, if you let the pressure get up a little bit higher, come back, and then you gently can try again later. So you need to be aware of that. I don't want to create my own CKD. I don't want you to lose 10, 15 ml of renal function and have a blood pressure of 120 versus 125. I think this is a mistake. So you have to be aware what happens with the eGFR. And that's particularly true. That's almost 1 out of 10 diabetics. If you too aggressively or too quickly or too low a pressure, I think that my favorite pressure for somebody with diabetes is between 125 to 130 to give you two goalposts. So if you just go below 130 and provided you can stand up and you can function, you will have achieved an excellent pressure. That same number would be also an excellent number for non-diabetics. So just below 130 and between 125 and 130 is probably the best number for everybody. So what about issues with people who have white coat syndrome? These are the people who are hypertensive in your office, and I've done this many times in the past before we knew this existed, and you give them a blood pressure pill, and then the next thing they call you up, I can't function, I'm dizzy, or somebody said, they almost passed out at home. And there are particular women, I don't know why, after age 50, who have a higher incidence of white coat syndrome. So the only way you can find this is to do home blood pressures. And I don't think why we don't do this more. If I prescribe a pill to you for diabetes, you keep checking your blood sugar usually, at least occasionally at home. With a blood pressure, we give them a blood pressure pill and tell them come back in 3 months, and nobody takes the reading in between. So I don't want you to take your pressure every day, but if you take it once or twice a week, if you have hypertension, that guarantees that you know where you are with your pressure. Number 2, you take your pills. So we need to get more home blood pressure involvement, not just for the doctor to know what the number is, and make sure that people don't take their pressure 8 times a day. I have these engineers that come out with graphs and they have it meaned out, and it becomes a new disease, blood pressure taking. So the one thing you have to know is if you have higher office pressures, but you're normotensive at home, you should not be treated, period. Okay, that's an absolute now. However, if you look at hundreds and hundreds of people who do this in their 50s or 60s, they have a higher chance of transitioning later on to hypertension. So not all of the white coat syndrome people become hypertensive, but some of them are at risk to develop hypertension later on. So much for that. So here's my favorite slide. If you take your pressure at home, you have a 2-to-1 correlation with events. So what counts is the home blood pressure, not the office pressure, okay? So the home blood pressure is much more important what cardiovascular-wise would happen to you. And also has a condition, I'll have extra slide on that, that's called masked hypertension. I don't know how to explain it, but when we go to those hypertensive meetings, there are hypertensives who feel so warm and cuddly when they come to a doctor's office, let's use that expression, and when they go out of there, they're hypertensive. And not because they're on the freeway or they're yelling at their spouses, but it is more than that. So basically, this is now as many as 10+% of all patients, and you will never make a diagnosis of somebody you see who's 125 in the office and 145 at home. How do you know? Well, as a physician, you should become suspicious that if they have AV nicking, if you look at their fundus, if they have LVH, I'll show you the slide in a moment. So you have to have an index of suspicion. And again, the answer is that people should have their blood pressure checked outside the office if they're hypertensive or normotensive to really make a diagnosis of masked hypertension. So you also are more likely to take your medications, you show up for visits, and actually basically the definition of hypertension is not made unless your pressure is high at home. Now, if somebody is 100/100 in the office or 160/95 in the office, they will not be normotensive at home, so don't kid yourself. Most of the white coat syndromes are just 10-15 millimeters above. So they're 150 in the office, 145, but they may be 10-15 points lower at home. So just give you an idea what the range of that condition is. And here comes the masked hypertension. Normotensive in the office, hypertensive at home. And the tip-off is that if you have target organ damage, unexplained, they have left ventricular hypertrophy, or their eGFR at age 58 with a normal-looking urine is down to 65 and 60 or less. So they have early CKD, much earlier than they should. Or they have a high ACC calculator risk. And very importantly, microalbuminuria is indicated for anybody who has obesity, anybody who is hypertensive, not just for the diabetics. It's the test has coding, so you get reimbursed because microalbuminuria is the best test for endothelial dysfunction. It is cheaper and much better than an HCRP. Because if you have microalbuminuria, by definition, irrespective of what other illnesses you have endothelial dysfunction. So that raises your risk. Because if you look at males with ED, a large number, probably at least a third or more, have microalbuminuria. So this is very important. So again, if you don't make a diagnosis of masked hypertension and they're hypertensive at home, they got the same complications like they would if they have hypertension all the time. So this is very important to make a diagnosis. Okay, let's get to the therapy. So basically now we have freedom. No more step care. No pharmacy provider will call you up and say, you have tried the thiazides first, they're the cheapest, because we have all drugs generic. So you decide of the 4 classes there, and you see there's no beta blockers. So beta blockers are not a first-line drug for hypertension. You have to have a reason for a beta blocker beyond hypertension. We heard earlier CHF, you have angina, there's some other condition, maybe you have uncontrolled atrial fib. So you have to have additional reasons. So if you are stage 1 and you have a risk of 10% or more, or you have underlying coronary artery disease already, you're diagnosed, you start with 1 drug and you titrate it up to the 85-100% dose. So if you on a 12.5 thiazide, you go to 25. We don't use 50 anymore. You don't treat people with volume depletion. If you start with an ACE inhibitor, the full dose is the 40 milligram. If you take 20 milligrams of lisinopril or benazepril, whatever, that is not the full dose. And if you are a nephrologist, if you don't use full doses of ACE inhibitors or ARBs, you have 0 renal protection. So I can give you a whole hour of discussion on a reduction of microalbuminuria or albuminuria or renal protection. Half dose or 1/3 doses of ACE or ARB do nothing for renal protection. You need to have the full dose. multiple studies done, if you remember Rinal and Irma and all these studies from 15 years ago. So again, from a renal protective standpoint, full doses are needed. And if you cough with 10 milligrams of lisinopril, and if you take 40, you don't cough 4 times as much. So basically, you either tolerate it or you don't. So this is the answer to that, okay? In your stage 2, if you are truly 150, 155, over 95 or 100, you will need 2 drugs. The chance of being controlled with 1 drug in full doses, if your pressure is 20/10 above goal, is 3%. You're not going to go to Vegas to gamble for 3% risk of a reward. So basically, you need 2 drugs. And we have so many combos. You can start with a baby doses of 2, or you can start 1 drug at a time and add the other one. So basically, you will need 2 drugs for that group. So what about comorbidities? Again, this is made it very easy. If you have diabetes, type 1 or type 2, or you have albuminuria, or your eGFR is less than 60, so you have CKD, you start treatment above 130/80, and your first line again is a thiazide, a calcium channel blocker, ACE or ARB. So there's no difference there unless you have albuminuria. So if you have albuminuria, then the ACE or ARB are the first drugs. Why? Because to reduce your albuminuria or microalbuminuria by about 40 to 50%. So I see all these people in consultation where the physician found albuminuria, and there was mild systolic was elevated, 140 or higher. So they start them on ACE inhibitors. They're on full doses. Their pressure's down to 132, and the albuminuria has only gone down by 10 to 20%. So I see the patient consultation. What's the answer? High salt intake. So if you can negate or totally attenuate or reduce the efficacy of an ACE inhibitor or an ARB to protect your kidney by just increasing your salt intake. And as I'll show in a moment, we now have magic salt intake. You heard it from the cardiologists for CHF. We're at 5 to 6 grams of salt, and you divide this by 2.5, you get the sodium. So you read sodium labels, you multiply it by 2.5, you get the salt. So we are between 5,000 to 6,000 milligrams of salt, which is 2,300 or so milligram of sodium. So this is the sweet spot for salt intake in a hypertensive and in people with renal disease. So we don't go to, if you go on a less than 3 gram sodium diet, you're harming yourself, even without CHF, because you will then stimulate the renin-angiotensin system. So you produce more angiotensin II, and you produce more aldosterone, which you're trying to fight. So it's not a good idea for any one of us, even without hypertension, to go on a low sodium diet. The sweet spot is 3 to 6. So ideally 5-6 grams of salt or sodium divided by 2.5 is the ideal amount. So beta blockers should not be used unless you have CHF or ischemic heart disease, and no atenolol. This drug is a garbage drug. It should be taken off the market. Why? Atenolol is never taken like it's supposed to. If you take it twice a day, it's good. If you take it once a day, it only works 17, 18 hours. So every single drug study done from a new drug, when I want to show you how good my new drug is, the pharmaceutical industry used atenolol as the comparator. So atenolol has actually lost every single drug study because they knew what to pick. They know the losers because they used it once a day. Okay, so now this is not me writing down. The American College of Cardiology and the American Heart Association says no atenolol. It took them 20 years. Last year was the first time ever it was absolutely stated in the meeting and stated in the guidelines. So anything I have on slide is not made up by me. These are all from the guidelines. Okay, so what about dosing? Remember the HOPE trial, which had these wonderful results on using ramipril, that they reduced cardiovascular events? Guess what the ramipril was given? It specifically had to be given at bedtime. So if you and I take an ACE inhibitor and ARB, we all should take the drug at bedtime. Why? Because if you do this for 5 years, and you say, I'm going to take it for 5 years in the morning, in the same dose for 5 years in the evening, and I have diabetes, you can see there you have 12% fewer cardiovascular event with the same dose. So if your kidney function is less than 60, it's 14%. And there are studies, I don't have them here, that even if you don't have any diseases, just hypertension, you have major benefits of at least 8% of lower events. Why? Because you and I have a circadian rhythm, and the highest blood pressure in the day is when you wake up, and that's when you take your pills. So you're two hours behind your major cardiovascular event. So if you take 3 drugs, thiazide and a calcium channel blocker, take the ACE inhibitor at AHS, and if you have a drug which has a calcium channel blocker and a ACE inhibitor in one pill, you take it HS. And what about the diuretics? Well, studies have been done. If you go down to 12.5 of thiazide, if you take it at 6 o'clock, it probably won't give you much nocturia. But overall, I think you're better off if the thiazides, you take them in the morning. So what about racial issues? African Americans, even with the same pressure, if you're Caucasian, it's 150, and you're an African American, it's also 150 systolic. When the cardiologists study them, they are more vasoconstricted, so they have a higher systemic vascular resistance, and they are much more salt sensitive. What does salt sensitivity mean? If I give you 10 grams of salt a day for 2-3 days, and your systolic goes up by 5 to 10 millimeters, you're salt sensitive. And there are some individuals who can take in a lot of salt and their pressure does not budge. So this is why we've gotten away from salt restriction of everybody, because we were mistreating large percentages of people unnecessarily. So again, being in about 5 to 6 grams of salt intake for hypertension, you're on a sweet spot. So African Americans, again, you prefer a thiazide, which gets rid of the extra salt because they're salt sensitive, or you use a calcium channel blocker, which is a vasodilator, which helps predominantly with their vasoconstriction. However, ACE inhibitors and ARBs work well in African Americans, but only if they also use a diuretic. So an ACE alone and an ARB alone has underwhelming benefits if you're black. So a thiazide will make up more. So the response to a thiazide with an ACE in an African American is almost as good as in a non-African Americans. But ACE alone is less beneficial. It's just to compare this for you from race to race. So what do we do for non-pharmacological ways? Well, nothing new. If you lose weight, and I think I can give you a number. You saw the number earlier this morning, about 80% of people with a BMI above 30 are hypertensive. And we now have numbers. If you lose 1 kilo, that is 2.2 pounds, your systolic goes down by 1 millimeter if you're hypertensive. Okay? So if somebody doesn't want any drugs and needs to, wants the pressure to go down by 10 millimeter, they're 140, you want them at 130, they have to lose 10 kilos, which is 22 pounds, which is not an easy task, but that would be equal to giving them therapy by drugs, okay? So the best diet, you heard it 5 times a day from any action there is Mediterranean diet. So the DASH diet, why is it so good? I'll show you an extra slide. It has double the amount of potassium and double the amount of magnesium in the diet from the fresh fruits and vegetables than you and I normally eat. And here comes the salt story. I'm not going to increase it. I want you to make an experiment with yourself, even if you have no diabetes, just for a day or two, go on a relatively high fruit or vegetable intake. Just, have a banana in the morning, some grapes at noon, and oranges in the afternoon. Just have more fresh fruit intake. You know what you will find? You start to piddle more like as if I gave you a diuretic. So you'll have actually a higher urine output of salt and water. Why is this? Because potassium is Mother Nature's antidote to high sodium intake. So our the ancestors who were eating a lot of plant diets, that was high in potassium and low in sodium. And now our diet is high in sodium and low in potassium. So we just turned it. It was 2-to-1 in favor of potassium. Now it's 2-to-1 in favor of salt. So basically, fresh fruits are indicated unless you eat your style less than 30, and then the nephrologist will give you some restriction, and so we know about activities. But basically, high potassium diet is very beneficial, and I have some additional slides to show you. It increases potassium naturases, has a thiazide-like effect, just published the last 5 years. It makes you less sensitive. So if you want to have more salt, increase your potassium, you have then a free lunch, so to speak of. And it also is renal protective. There were some recent papers showing that 15% of all people with CKD have either a low potassium, below 4, or a high potassium above 5. So the sweet spot for potassium for all my hypertensives always has been 4 to 4.5. And there are actually studies, if somebody is on a thiazide and the potassium goes to 3.5, they become resistant to the action of a thiazide. So the same happens, the cardiologists know that. So low potassium actually is counter-regulatory to the blood pressure. So a case of 4 to 4.5 for hypertension, for arrhythmias, and for all other actions, renal protection if you have CKD is very advantageous. For pregnancy, well, our lawyers made sure that nothing changes the last 50 years in this country. So if you live in Europe, you'll get labetalol, and you don't make your pregnant ladies first so sleepy they can't open their eyes with a methyl dopa, and so edematous with a nifedipine they can't walk around anymore on top of the pregnancy. So basically, you have to document the methyl dopa didn't work, you have to document the nifedipine didn't work, and then you can write the prescription for labetalol, because God forbid, if there's a birth defect, they're going to blame it on labetalol, which is not true. The drug has been used extensively for 30 years in Europe. So we don't use ACE and diuretics, so you're already aware of that. So what about NSAIDs? You have no idea how the NSAIDs, I know how many $1 billion of NSAIDs were consumed over the counter, so this is a horrendous use of people over the counter. What the trouble is, if you don't have hypertension and you use it on and off, or even daily in some lower doses, you're fine. But if you take it every day and you have hypertension, you become salt sensitive. That means the amount of salt you take in, it gets supercharged. So, and if you have an EGFR below 60, you lose 10, 15, 20 ml. So I've seen people go from a creatinine of 2 to 2.5 within 3 days of ibuprofen, 600 milligrams twice a day. And so if you don't have CKD, it doesn't touch your renal function, but you need prostaglandins if you have an EGFR below 60. So what basically I want you to be aware of is that if you are hypertensive, you lose the efficacy of your antihypertensive drug by 10 to 15%, except for calcium channel blocker. Example, 75-year-old male, blood pressure is 145. You need to treat him because it's confirmed at home, but he or she has osteoarthritis. So what do? You take a calcium channel blocker, because that drug is the only antihypertensive class which has absolutely no interference. So whether you take an NSAID or you don't take it, it has the same efficacy. Okay, so this is worthwhile knowing, because all other drugs you get attenuated. If I see patients who are beautifully controlled with their hypertension, or their renal function was very stable, and they see me, I usually ask them, did you see your friendly orthopedist recently, because you usually used an NSAID? Or then I go through the list of the NSAIDs which are available OTC, and I usually catch either it's the orthopedist or the OTC market, which is responsible. Okay, there are 9 drugs now for the tyrosine kinase inhibitors, which inhibit the growth of new vessels, but they block out nitrogen. So 50% of the patients treated for breast cancer or other cancer to reduce metastasis are now hypertensive from the VEGF antagonists. And it is an irony, the more hypertensive you get with these drugs for chemotherapy, the more benefit you have from an oncology standpoint. So if you have no hypertension at all, the drug probably doesn't help you very much. So that's almost like the side effect tells you the response of how much nitric oxide you knock out. So if somebody has a very good response to the drug from an oncology standpoint, becomes hypertensive, the best drug to use is big dose calcium channel blockers, because they're the vasodilators. But don't use diltiazem, verapamil, because they're metabolized by P450, so you interfere with the metabolism of the tyrosine inhibitors. Okay, because we heard so much on obesity, I put this slide in there. We now have figured out what happens. If you're obese, your fat cells, the adipocytes in your abdomen, in the visceral omentum, produce leptin. Leptin originally was supposed to go to the brain to suppress your appetite, but it doesn't work anymore because you've gotten used to the leptin. But hyperleptinemia is the main reason you become hypertensive. And there are two different actions. In the males, it increases more the sympathetic tone. So their pulse rate goes up, their cardiac output goes up. But in females, it's mostly aldosterone. And I knew this long time ago. If you see an obese woman postmenopausal, that there is a marvelous response with hypertension, the low-dose aldactone. So in the past, we have gotten carried away. You can start somebody on 12.5 aldactone 3 times a week. The drug works 72 hours. And you get very nice blood pressure reduction, and you don't have to worry about potassium. Then you go to every day, or you go to max 25 milligrams. So please consider even pediatric doses, let's use the word, of aldactone, particularly in obese postmenopausal women, and you'll have actually, as a monotherapy, an excellent response to hypertension or as an add-on. So very quickly in the last couple of minutes about the resistant hypertension. So if you are not controlled down to 130 over 80 or 135 or 85, you're like that, and you're already on 25 of thiazide, you're taking 40 lisinopril and 10 amlodipine, we call you then resistant. We used to call them refractory and all kinds of other words, or malignant, whatever we call it. Now it's only one word, resistant hypertension. So the trouble is that the number one cause is that people don't take their pills. And number 2 is they drink so much alcohol, they eat so much salt, they neutralize your drugs. Or they take NSAIDs, already covered that. But from a therapeutic standpoint, if you can control their salt, you can't control anything else they do, but you can give them aldactone. So if you give them low-dose aldactone, you can give them 12.5, and people cannot tolerate aldactone because they get breast tenderness or some other side effects they don't like, which is rare. You can give them amiloride. It's dirt cheap. You can use 5 to 10 milligrams, or there's eplerenone. So we have alternatives which will not give breast tenderness in the males or cause otherwise side effects. So that's the issue with that. Okay, so what you do is, if you're resistant, you measure urinary spot sodium, so you see that they don't take 12 grams of salt in. You increase their potassium intake. Look at this. You get 7 millimeters almost by doubling your potassium intake, fresh fruits and vegetables. And you switch to chlorthalidone. Chlorthalidone gives you 6 millimeters more systolic. So if you're 146 on 12.5 of thiazide and 40 lisinopril and 10 of amlodipine, and I just take your thiazide away, and I give you 12.5 or chlorthalidone, I get 5-6 more millimeters of blood pressure reduction. Okay. So you don't have to go to a 4th drug by just switching out chlorthalidone, okay, and then ACE inhibitors in full doses, and then again over aldactone. I made a living with that as a hypertensive specialist. So this is how you control and get you good remarks from your as a consultant. Don't use beta blockers unless there's a reason, but if your pulse is over 80 and you have normal thyroid function, so you have a very high cardiac output, you can control blood pressure, you cannot. So if somebody's pulse is 80, 85 with hypertension and they're not anxious and their thyroid function is normal, you have to use a beta blocker. But there we use the vasodilating beta blocker, and our drugs of choice is nebivolol, the all bistolic is now generic, or carvedilol, which is a BID. And these beta blockers, by the way, do not cause diabetes. And nebivolol does not cause ED, erectile dysfunction. So I've seen males in their studies too who are on 50 milligrams of tenormin or atenolol or other beta blockers, metoprolol, they develop erectile dysfunction. If they are on that for hypertension, you switch to nebivolol, and you will very often don't have to write the prescription for the ED drugs. So this is just something for you to consider. So in summary, the categories for hypertension now is if you're above from 130 to 139, you're hypertensive. If you have a high risk score or known cardiovascular disease, you treat. Otherwise, you delay 3 to 6 months and do lifestyle alone. If you have cardiovascular issues or high risk score, you treat immediately. And if you're above 140, you have to usually use 2 drugs. Okay. And just to the last slide, a note on what the Europeans do. They're a little bit more conservative, and if your pressure is above 140 over 90 in adults, they do go down to 130, but they do it initially slower. And as you can see, they have an age limit. So if you're younger than 65, they definitely get you down to 130 or just below. But if you're over 65 or you're acting like you're over 65 as a 50-year-old, they treat you a little bit gentler because you have to stand up and you have to function. So I think this was just published 2 days ago online initially, and was in the paper by the JML a couple of days ago. So basically what it shows you is that there is a more gentle approach, but the goals are the same. Get the pressure as close to or just below 130. Thank you very much. It's time for lunch.